Now, after we talk about the heart preload and afterload, and we talk the shock types and the recognition guide, we will go for the first management in the shock type and each management how it can be. As we said, the core principle here we need to know. Okay, the principle which I said before that the late sign for pediatric shock is hypotension, but the early sign in pediatric shock is tachycardia. So once I got pediatric patient in PICU, his heart rate become abnormal, tachycardia, then I expect shock, especially if there is also poor perfusion. Poor perfusion, how I can detect? Through some parameters like urine output, like increasing lactate. These are signs for poor perfusion. First, hypovolemic shock, as we see here, the mechanism as we talk about, distributive and cardiogenic and obstructive. Fluid resuscitation. Fluid resuscitation, if you remember, at which type of shock we will use. Of course, in hypovolemic, this is the first one, and in distributive shock, somehow in cardiogenic with caution, and an obstructive shock with removing the obstruction. We will talk about the signs of shock in pediatric, the early sign tachycardia, delayed capillary lethal time, cool extremities, mental status change, decreased urine output, and weak peripheral pulses. But late sign, which is danger, like hypotension, considered pre-arrest finding, bradycardia, and cyanosis, and multi-organ dysfunction. Fluid resuscitation, I will start with bolus. It's considered like a standard in most of pediatric population, especially in some exception, with 20 ml per kg from isotonic, crystalloid, normal saline, or lactate ringer. And lactate ringer or plasma light, it is preferred because if the patient is heavyweight and he need more amount of fluid and I use normal saline, there is some risk of hyperchloremic acidosis because of high percentage of chloride in the normal saline, so can cause kind of acidosis. But plasma light, it is much closer near to the blood component, so it is preferred according to latest guideline, and the lactate ringer also can be alternative. Here also you can catch another mistake happen in the BICU that uh, they are providing the patient with bolus after bolus and monitoring the general parameters of the perfusion without reassess the patient to fluid response. There is something called patient fluid response. After each resuscitation, I need to evaluate the patient. He responding to the fluid or no. But the problem that in practice they are giving resuscitation and they repeat it without re-evaluate the patient, and this can cause simply developed from under hydration or dehydration to overhydration, the fluid congestion and the fluid overload, especially in condition of cardiogenic shock. If the heart has a condition like heart failure or congestive ischemic heart disease, and I give the patient fluid more than the desired volume, this it give me a risk of fluid overload. So I need after each bolus to reassess the patient through heart rate, through capillary refill time, through urine output, through lactate to confirm that circulation improved without fluid overload risk. What is the maximum of bolus? I will give the patient 20 ml per kg, especially in first hour. Then if I need to repeat the bolus, what is my upper limit maximum in pediatric population? If the patient in the ICU, PICU, the maximum 60. If the patient outside PICU, the maximum is 40 ml per kg in the first hour. In cardiogenic, see here, the rate is difference, only 5 to 10, because as we said, the heart has a problem. So I will use only rate of 5 to 10 ml per kg as bolus to avoid volume overload. If you can see here, there is some safety alert at the end that repeated bolus without reassessment can cause to pulmonary edema, acute respiratory distress syndrome, worsening cardiogenic shock. So after each bolus, I need to reassess the patient. And here there's example, patient 25 kg child, he received 20 ml per kg, which means 500 ml lactate ringer bolus, maximum single bolus 20 ml per kg, check vital labs after each, and as we said, maximum if the patient in PICU 60, outside PICU the maximum limit is 40.